Hi, everybody. My name is Theresa Berner. I will be moderating your session today and co-presenting with Wendy Koesters. Welcome to session IC14, Shoulder Surgery, Therapist Role in Prevention and Preparation. I will provide the CEU code at the end, and I will also put it in the chat. Before we get started, please remember to mute yourself. Questions can be asked using the chat feature. And I will go ahead and try to answer as we go, but we will leave some time at the end as well. So I'm going to go ahead and turn it over to Wendy and myself to get started. Like I said, I'd like to welcome you. Wendy Koesters is a physical therapist. She has been working for 15 years in seating and positioning. She works with me on some adapted cycling, and I love that she's titling herself an adapted cycling enthusiast. She's very enthusiastic about a lot of things surrounding seating and positioning, and she's also a national park junkie. She gets out and about when she's not in the clinic. I am an occupational therapist. I'm in my 29th year, so I've been around for a while and always excited to see all the fun stuff going on, and really honored to be Wendy's sidekick for this session. We have an Adapted Sports Institute that we'll talk about a little bit, and I'm also a community ambassador for Adapted Sports. Next, so we do not have any conflicts of interest related to this content, and our objectives are: we hope that you will find 3 shoulder injuries that manual wheelchair users are high risk for. We hope you'll be able to name 3 special tests to rule in subacromial impingement based on clinical prediction rules. This is something that Wendy taught me that I didn't get in my schooling, so I'm excited for her to share this. And then we hope that you'll identify 4 functional concerns to address in preparation for optimal independence and health for manual wheelchair users post-shoulder surgery. And we have a lot of really good cases, and Wendy will talk to you about some of her experience that hopefully you'll be able to get some golden nuggets to apply in your clinic. So our outline is we're going to go over the wheelchair user shoulder pain incidence, impact, and progression. We're going to talk about the therapist's unique skill set, talk through some assessment strategies and resources. We'll offer what we do for education for clients. You guys all know the wheelchair prescription, and again, looking at surgery considerations pre and post. So I'm going to turn it over to Wendy for the fun nut of it, and I'll be back shortly.
Yeah, so thanks, Theresa. So I've worked in the seating clinic exclusively for the past 15 years, and this is a repeat theme that keeps coming up, definitely with spinal cord injury a lot, and that's what we see a lot of this research is based upon, but just the high percentage of manual wheelchair users that experience pain and how this impacts their day-to-day lifestyle. Certain factors put individuals at a higher risk, and those are listed there, with the shoulder joint being the most prevalent. But those risk factors are the older age, the longer time since injury, of course, their level of lesion for a spinal cord, and female, specifically impacting the wrist, are big ones at play. And so a lot of the time, rotator cuff tears and tendonitis are the most common. And look at this percentage here of 63% to have a rotator cuff tear of manual wheelchair users versus able-bodied. These statistics are things that I think you can use clinically, of giving that feedback and the risk factors for our clients early rather than too late. And just like those factors listed earlier, that rotator cuff tear prevalence increases the longer post-injury. It's pretty uncommon for this population of manual wheelchair users to undergo surgery, just the effect that it impacts their lifestyle. So with the high risk or report of pain, only 2% with that research study undergo surgery. And I'd say clinically, that's pretty accurate. But we as therapists have a really unique role. If we can help to decrease some of that shoulder pain through interventions, habits, exercise, equipment configuration, the benefits are pretty immense to our clients, socially and quality of life. So upper extremity pain, lots of things that this is going to impact. And The impact on function are the big ones here. None of our clients want to lose their independence, require more assistance, cost that happens. And with less activity, less independence, life is going to get a lot more narrow. That's a term one of my clients used that really stuck with me one time, of their ability to get out and about on their own. That disuse is going to lead to that whole metabolic syndrome of cardiovascular disease and obesity. And that cycle just keeps on going, impacting that lower quality of life for sports, wellness, work, socialization. So these are a few of my clients here who are great models of some of those predisposing factors for our wheelchair users. The level of injury, muscle tone, traumatic injuries have an impact on sitting posture and muscle imbalance. Highly repetitive tasks for manual wheelchair users and that weight bearing that occurs. Our shoulders are not as stable as our hips when we're ambulatory. And then the two where you can see their wheelchairs, you can see the improper wheelchair configuration definitely has an impact. And all three of these clients have shoulder issues. So the gentleman in top sporting his Buckeye gear, he is way too far anterior from the axle. And the lady on the bottom, she has a ton of load onto those front casters. So those are definitely things that we can have an impact as therapists. So for many of our clients, surgery is the last resort. They're going to hold off, like our ambulatory clients, until there's no other option. That pain, loss of strength impacting their transfers, their ability to drive. They have no other choice but to go this route, but they need to understand all the pre-op or post-op implications. Specifically, what are they not going to be able to do? For many clients, it can be anywhere from 6 to 12 weeks, depending the type of surgery, that they're going to be immobilized and non-weight bearing. So they're probably going to be a dependent transfer, need alternate equipment through that time frame, and with that lack of independence, so secondary complications of skin, overuse of other areas are big factors at play and points that we want them to weigh out. Theresa?
We wanted to just pause and give you some perspective of kind of our system of care and what we have, and recognizing that you guys are in various roles. Throughout my career, I've had a chance to really kind of live through different models, and knowing that one isn't the exact perfect compared to the other, and I've had an evolution of it. And when it comes to shoulder pain and prevention and setup, it's really an evolution. Early in my career, I would see somebody for their wheelchair, and I would see them 4 years later for their second wheelchair. And then even when I would see them for their second wheelchair, there was so much that I learned about setup and wheelchair use, because our industry has really evolved. And some of my patients were like, well, you didn't tell me that last time. It's like, because I didn't know. But now we don't see people just every 4 years. We see them as a continuation. We see them for follow-up, and we see them out in the community for sports. And, you know, we have a system here where inpatient to outpatient, and sometimes they're readmitted to inpatient. And I've really learned that the role of a seating therapist is so important. You guys may be there where you're an outpatient therapist and you see somebody for regular intervention, not just for their seating, or you may be somebody that only sees them for seating. So I want to talk a little bit about the role. The awareness of injury intervention and prevention is so powerful, because it's something that we all read and we know of, but the application as the athlete that Wendy is with here is where sometimes I feel like we miss the boat. Being able to take that orthopedic component into the biomechanics and the strength and flexibility when it comes to the orthopedic components of what's going on at the shoulder joint is something that we may not realize we have as seating specialists. And we all talk about equipment fitting and skill of use, but how are we implementing that? So the next slide, you see my background at Ohio State here. I'm sitting in the stadium. So if you are familiar with OSU, we have the best damn band in the land, which is Tabittle. And our colleague Carmen came up with, Wendy, the next slide, the best damn AT center in the land. So this is a picture. Some people have retired, some people have moved, but there's a core group of people in here that are still part of our team. And there's some newbies that aren't represented that are with us virtually now. that we want to provide the best services to our patients that we can, no matter where they're at in their process. So the next slide. This is the wheelchair service delivery. And if you sat in Mary Shea and Jessica's presentation earlier, looking at the service delivery, we want to live this. We want to live it through the referral intake to the follow up and follow along. And this has been hard for us as an industry to have touch points with our patients. But a lot of what Wendy's talking about today is her ability to continue to have those touch points. So even when we've exhausted manual wheelchair mobility, and we need to go to power, we have that readiness. Or we've had some cases that the individuals were preparing for shoulder surgery. We were able to, well, Wendy was able to be a really important part for the planning ahead of time. So we don't take it lightly as far as the touch points that we have, and we hope we can share this with some of you guys. The next slide shows a program that we started. We found that the wheelchair athletes were a group that weren't getting the intervention, because if they did recognize that they had shoulder pain, because a lot of them, they just persevere. And I've had a lot of individuals tell me, well, this is nothing compared to my injury. They just push through it because they're warriors. But if they would go to get some intervention, they would go to a sports medicine doctor because they perceive themselves as athletes. Well, the sports medicine doctor may do some injections and address the shoulder, but they're not addressing the whole integration of that chair and the setup and the strengthening, that holistic part of that individual. So the next slide shows how we defined our mission and looking at adapted sports within the seating clinician. I think the VA does this really, really well because it's part of your service delivery. But I think a lot of us are left out of this. And I think a lot of athletes are just going to their buddies to get chairs fit for them, which is not the model that we want. And again, the VA has the best model. So if you're on the line or on the virtual with VA, kudos to you. But the next slide shows how we've kind of taken this concept and we've integrated. We have the medical model, we're integrating it with the community to be able to grab people no matter where they're at, not once every 4 years. And then we've been able to really use our academic medical center to collaborate with the entities that can study this over time so we can help contribute to having that cycle continue to go on. So I'm going to pass it back to Wendy. Oh, so then we have the follow-up so that not only we see them once every 4 years, but we're able to see them in synchronous times. Maybe it is a month, maybe it's 2 months, maybe it's 6 months, but we definitely have touch points every year that we're able to assess their health and well-being. So now I'm going to pass it back to Wendy.
Yeah, so I found that when being my career in neuro primarily, and it was really when I got into adapted sports and I started to see what the strain and how the pain was impacting their ability to do what they loved, is really needed to beef up my orthopedic skills and how I could assess and what kind of strategies I could provide to my clients. And so as clinical specialists, it's not just understanding their equipment or their progression anticipated with their disease process or their injury, but we really got to have that strong orthopedic skills. And so with that HAT model of a previous slide, we got to be able to monitor the warning signs based on their life roles and their activities and what the technology that's used. And so these are the ones that I'm educating my clients about early and often, that these are things you shouldn't ignore. It's not just me as your seating therapist, but also your family doctor, your PM&R, that you should be talking about shoulder problems, arm problems. And so that's something that's overlooked too often when we're thinking about bowel and bladder or maybe skin. And so these are warning signs that I give clients through handouts, when I'm physically assessing them too, of things that they should not ignore. So with the screening, this is something I like to do when I meet a client for my first assessment, that 6 month, that year follow-up, and I'm monitoring over time what's happening with our clients. They'll be like, oh yeah, I remember you talking about this a year ago, and this is what's changed since that time. So just kind of establishing that relationship with our clients is so key. And I just want to be that person they can come to when those warning signs or their function is being negatively impacted. So with posture, these are some things that we're going to look through, but with range, we really got to rule out capsular tightness. So with those orthopedic skills, we know that the greatest limitations are going to be in abduction and external rotation. But there's very common with hemiplegia, depending on the level of the spinal cord injury or trauma, that there could be instability too. So we need to teach people to be cautious with the way that they lay in bed, passive range of motion, and resistive exercises. So we're going to go through some of these shoulder screening activities here. So with that quote that's listed at the bottom here, this is going to kind of be a repeat theme as we go through some of the intervention or assessment strategies, but I really have to understand the client and what's affecting that posture and balance control before I can have an impact either with exercise, education, and their home program. So there are clinical prediction rules that rule in and rule out different items. Many times you can go through subjective history alone to kind of help rule in what's happening. And then these clinical prediction rules just help fine tune it further from there. So example, with rotator cuff impairments, clients are going to compare or complain of referred pain, typically to the lateral region of their shoulder, pain at night, pain with elevation. And with arthritic conditions, it's going to be like the AC joint is going to be just more kind of stiff and achy throughout the whole day. Special tests, like I said, help fine tune. And so those are what the upper ones are. And these are the most common injuries for manual wheelchair users for us to keep our eye out for. For example, with cervical radiculopathy, the grouping of tests, if someone is 3 out of 4 positive, that's a 94% specificity for that specific impairment. So specifically for subacromial impingement, which we see so often with our clients, maybe their wheelchair is too wide, they reach with their thumb down. Those are all reasons that they're going to continue to pinch within the shoulder, could be their propulsion stroke strategy. But those 5 listed tests there are the big ones. Some of these are active, some are passive, some have resistance. So I'm just going to play it by ear for what the client can tolerate and how significant their pain level is. In the handout, I do have all listed of these clinical prediction rules and kind of a way that I educate clients on this is what this means. This is how you can talk with your doctor. And these are activities that you can work to modify or avoid. When I first started this presentation, I had double the slides of what I have for you here. I have crazy amounts of case studies. I'm very passionate about this. And so this is a scaled down model of what I have the time limited to do with you here. Some outcome tools to kind of compare over time, especially with those checkpoints that we talked about. These are some big ones that we'll use. So the manual wheelchair skills test doesn't have a minimal detectable change, but it's a great comparative tool with intervention, new equipment, or just time frame. The WUSP, the Wheelchair User Shoulder Pain Index, is one I do I don't know how many times a day, but this is a great one to set a goal for because there is a minimal detectable change there, really easy to quantify. And research has supported this. When I look at research about shoulder pain for manual wheelchair users, this is kind of the gold standard of the one that's used. Very quick and easy in the clinical too, in the clinic. The DASH is one I don't use quite as often, but if people have specific tasks that are challenged, that might be applicable to use in that realm. And those orthopedic therapists were used to that. But propulsion speed is a great one too, that I can set goals upon as well. What is community norm is 1.29 meters per second. That is faster than ambulation. And the detectable change is 0.59. So great again to compare over time. As far as moving on to the next area, and this is one that I take to heart, is I want clients to have knowledge, me not just telling them, but how do you impart this into your day-to-day activity? And so with therapeutic intervention, activity modification, joint protection, handouts are key. Practicing with clients, things that they can do. So specifically, if a client transfers and they have a lot of internal rotation to their wrist, that's going to cause impingement. So practicing different methods of that. When they reach into their backpack behind them, that's a lot of internal rotation as well. Is there a different way that you can carry your go bag, your supplies? If you can lift items closer to your body, keeping the weight at a mechanical advantage, trying to keep the height in that repetitive strain. If you can put your most commonly used items at a more manageable position. What's your position that you sleep with at night? Many of my clients complain of pain at night, but they don't know how to modify what they're doing to make that more tolerable and less strain. And also, how do you access your computer? Gaming, work tasks. APTA has some resources, but sometimes with neurologic involvement, we need to get a little bit more creative than that. When it comes to joint protection, I don't want people to prop on their elbows seated or laying in bed. When people have poor balance and they brace upon their tire and have that repetitive strain. And another one too is when they do a lot of hook daily onto their push cane, that can have a lot of strain to the shoulder too. So my goal is that I'm observing more than I'm talking to kind of pick up on these tidbits that could help the client in day-to-day activity movement. Basically, it comes down to planning your day. What are your most frequent tasks? Can you fine tune that you're not doing as often of transfers? There are things that we can do to kind of help manage pain and inflammation in the upper right there, but it's got to be unique to the individual and understanding what their needs are and what they can follow through with on their own too for that home program. Whoops. So these are good quotes from an article of ask yourself when I'm out pushing my chair, what am I doing to re-lengthen those pushing muscles? So many of our clients have so much tightness in their anterior chest, and we need to get that power and that muscle balance in the back. And I liked this idea of exercise of being the daily vitamins that help fill in the gaps of what you don't get enough of on a daily basis. So a lot of times it's perspective and planning your day. And my goal is to give opportunity, things to consider, and the right resources for our clients. So my typical prescription of a home program is to think about posture. A lot of the times that comes down to habits and how your equipment is set up for you to be successful. I tell people maybe at their computer to put a sticky note for a reminder to do some stretches or shoulder rolls, those types of things. If you drive a lot and you get to a stoplight, to make some changes. And especially for those who are at our computer a lot, to make some scheduled breaks. You get so focused on what you're doing. We recommend people with back pain to stand up every hour. Why aren't we making those same suggestions to our clients who are wheelchair users of finding their own way of taking the strain away? Stretching, great in the doorway to do a pec stretch throughout the day. For those of our clients who can't balance to do that, I give letters of H, V, T, and goalpost to help stretch out those pecs when they're lying down. That's our role as therapists, to be creative. For cardio, there are definitely from strength in both cardiac education and guidelines for clients with spinal cord injury. I challenge you to look those up, but helping find our clients ways that they can get cardio that they somewhat enjoy. So ergometers, ski machines, rowing, dancing, boxing, YouTube, got all kinds of options. And then how Theresa and I have definitely over the last 5 to 10 years are reaching out to the community of what are those community-based options, and really challenge yourself to get involved. When you meet those community programmers and know firsthand what those clients can expect and the type of peer mentorship they're going to get, it's invaluable. So a written plan is a big deal. Coworker Kevin Starr and I developed this for a quad rugby team, and their power and their speed with the basketball team improved by doing these activities here. So again, these are focusing on not the push muscles, not the front of the chest, but that rear shoulder. I read a lot of articles to help fine tune what I'm teaching my clients, but the overlying themes are be active, don't be afraid to be active, and focus on that posterior shoulder, keeping a stable scapula. It's important that we as therapists understand exercise intensity and considerations with spinal cord injury, blood pressure, hydration, temperature management. Those are big things for us to understand too when we're teaching exercises, as well as community sports and wellness too. Theresa, do you want to talk a little bit about this calendar?
So this is a calendar that we have designed and maintained because in Columbus, we have a lot of really great organizations, but we don't have one central place to find out what is going on. And I think in our industry that is common, that if you're not an insider and you don't know who those people are, it's hard to keep up with it. So as Wendy said, a large role in the prevention of needing to get to that shoulder surgery is keeping people active and helping them know what it is available. And so this is a way that we can help engage them and connect them to the community. On the flip side, as Wendy said, when they know who we are out in the community, if there is somebody that is not progressing as they want to because shoulder pain is a barrier to their sport, they can refer them into us so that we can help prepare them and get their body in the best shape so they can be successful in the activities if they're meaningful to them.
So equipment is a big part of what we can do to help keep our clients healthy and prevent, if not prepare for shoulder surgery. And so I want to kind of give some of those nuggets of things that I wish I would have known when I was first starting to practice with seating and positioning. Manual wheelchairs, customized manual wheelchairs. This is my favorite thing to do. And I don't take lightly making changes to equipment, and I want my clients to be thoroughly involved and experience what to expect versus me just telling them what they have to have. These are main factors that I come back to when I check their current equipment. I take into consideration what I found with that shoulder screen when I'm going through the configuration, maybe changes to their current equipment or all new. So I want to make sure that my target is meeting that client's activity, what their functional goals are. It's very common that I think it would be better for the shoulder to be a client sat a little higher. But if they can't reach to the floor, if you're like me and have crazy short arms in relation to my torso, that would be a really negative impact in a choice that the clients would not like that chair that they'd have for the next 3 to 6 years. I ask patients to tell me and how often are they reaching back and overhead, especially with kids or work tasks. And so I think it was Ian Cooper that came up with this tippy test. So when you lean backward and reach up of how stable their chair is, that really gets into that caster weight distribution, which is bullet point number 3. We have a scale with a platform that I put just the casters in a consistent position, and then I divide that by the weight of the entire chair with them in it. And when I take that weight on the casters, their hands are at the wheels. So it's that active push position. I don't want there to be too much load on those front casters. If that's the case, my comparison, if the number is high, percentage is 35 to 40%, it's like you're pushing through mud all the time in that repetitive strain. But if that number is too low, if I did that tippy test, they could be landing on their head. So these are things that when I'm trialing equipment, making modifications, I keep coming back to what's your balance point? How much weight is on those casters? And how does that impact your ability to propel the chair without bouncing too much and go up ramps? So with access to the tire, I've got a really good picture coming up that I show to my clients all the time, and I'll bring a mirror over and compare it to their current position. But their access to the tire is really important, as well as what the width and height is, that they're not doing excessive strain just to grab that tire. We take a lot of focus into what are every last detail and part of that chair. We want to keep the weight as low as possible. But, I have clients saying, I want my chair to be 5 pounds lighter. And then I pick up their backpack and I say, whoo, this is a spot right here. You could help to minimize potentially. We've got a great handout up ahead of considering rolling resistance, and has made some of my clients who have been using chairs for 10 to 20 years kind of maybe rethink some of the choices that they've made in the past. And I want to have data that I can compare pre and post. What's their wheelchair skills test, those day-to-day tasks. So I've got that website there for Kirby. We actually have a setup of this in our clinic that we can do different degree ramps, curbs, side slopes, a pothole. It's wonderful. And then this propulsion assessment that I talked about, the minimal detective change, the community norms, to compare that over time too. So with this configuration, this gentleman right here has a really good degree of elbow flexion. This gentleman right here, I'm looking at where his shoulder is in relation to the tire. And I'd love for his third finger to be able to reach that tire too. So those are just some examples of kind of putting into practice some of these equipment configuration. So with this pathway, we already talked about the screening of the orthopedic considerations. I want to know their level of current function. How independent are they with transfers, self-care activities, community access? And I want the client to tell me what their goals are. And so I have specific questions that I'll ask my clients to kind of help fine tune how they use their equipment and what those priorities are. Those outcome measures, the wheelchair skills test, the WUSP, grip strength is one. That's not really an outcome measure, but that's a big one too when we're considering what parts and pieces are. And pictures are so valuable of current versus new. So I really want to understand how they function in their current seating, and then request the vendor at my follow-up appointment to set up a trial for us. And I'm going to be with them throughout the whole cycle. So that service delivery model of implementation and that follow-up in 6 to yearly intervals. So what I want to do is I just want to start that conversation. We use the functional mobility assessment outcome tool to help kind of highlight and fine tune. And we're going to keep coming back to this assessment tool over time to make sure that we've hit their goals. I want to understand their activity, their environment, what's working, what's not. And like I keep repeating, observe more than you talk. And that's understanding their must-haves versus preference. I just read that in a new mobility article, and I've been parroting that back in the clinic a lot. So from start to finish, if we're going to modify their current frame, that really helps us probably more than anything that I can pull off of our shelf or a vendor can provide. I want them involved line by line when we go through the order of, if we make this change, how, what, why, where can you expect for changes? Ideally, I'd like the chair to be as long and low whenever possible. That's for that weight distribution to the casters, stability on ramps. And then I want to observe when I make changes or how they are right here. I don't want people fighting for their balance. I can see that. Can they have a symmetrical push is the way to watch that too. Can they transfer independently? Can they reach the floor? And how do they do with those wheelchair skills? So this is a drawing, and I got this years ago. I don't even remember from where. I'm sorry that I can't cite it. But if I pull up a mirror and have a client look of their access for that blue vertical line from shoulder to axilla, I'd like them to be behind the axle, not axilla. That degree of elbow flexion, seat slope typically helps with balance stability. And when their hand comes down, I'd like their third finger to be around that the axle where that horizontal orange line is. So these are friends. They were in the clinic at the same time. And if you had to think, I know you can't talk to me right now, but which one of these has shoulder pain? The girl on the right, her chair is significantly wider than her hips. She is seated really low in relation to that wheel with her arm length. Just look at the degree of elbow flexion that's happening there. And if you saw them from the front, the girl in the red is also significantly more internally rotated. And so what I'm getting at, she's the one who has the most shoulder problems. This gentleman right here, we modified his frame within the visit that he was there. The original setup on the left had no seat slope. That's that yellow line. He was in front of the axle. That's the blue vertical line. It was a very short frame. His feet kept falling forward, which had a really negative effect on balance. And he has a very low seat to floor. So weight distribution was very high to those casters at 58%. I told you my target was around 20 to 25. Because it was so forward loaded, he was very tippy. He's got a very physical job, lifting, pushing, pulling, and no surprise, he has a lot of shoulder pain. So some of the changes that we did is we added 1.5 inches of seat slope, which gave him better access to the axle. We flipped the foot plate interiorly, which gave him more stability, specifically on ramps. He did not want to change the seat to floor. Home work, that was a priority that he was able to get to the ground. These changes, he went home and lived with this for a few weeks, really helped to guide our wheelchair prescription, drop that cast percentage closer to kind of my ideal. And he was able to do ramps. He felt better supported and balanced just with seated, not dynamic tasks. And my favorite quote for him is that it was easier to push.
Wendy, there's a question about how do you measure the caster weight distribution? I know you listed that earlier, but could you explain that again?
Yeah, so we have a scale, a wheelchair scale, and we had a student make a platform for us that we can attach to that, because for most gentlemen, like the gentleman in the past, his chair takes up the majority of the wheelchair scale. So with that platform, I just stay consistent by, we have grooves in it, and I put the caster on like the third groove. I have his hand onto, so only his casters are on the scale, but it's horizontal, it's level, this platform with the scale. And then I have him roll all the way on and take a comparative weight of him entirely in the chair. So that division of weight to the casters with the hands in a consistent position, wheels in a consistent position, versus the entire frame.
Thank you.
So Theresa, do you want to talk about some education that we can give?
Yeah, and I also wanted to say that, we're talking a lot about the prevention, because I think the therapist's role is really important to lead up to this shoulder surgery. And then we are going to get quickly into some of the plans for the shoulder surgery. But a lot of what we're saying happens over multiple visits. So kind of another one of my soapboxes is, trying to do everything in one visit. I know some seating clinics have utilized telehealth to break up some of the sessions or to get the information early on. But, some of you have maybe really long sessions, and we are able to do it over multiple times. So just to try to show you how there's so many opportunities and things that you can do if you stretch out the visits, because you can't always do everything in one visit. That's just one of my platforms. As I'm listening to Wendy, I'm just trying to visualize where many of you are and thinking how you can implement this.
And just that case study right there, the physician saw him, I saw him on day 1. Day 2 was modifying his frame. And session 3 was assessing the impact of those changes and trialing power add-ons. And at that point, we were able to write a prescription, but these were lengthy appointments. The fitting process, once funding is secured, I will see him back within a few weeks, and then we'll have follow-up from there as needed. So that just kind of gives a timeline of how clinically we are our service delivery model.
Thanks, Wendy. And a lot of what we're talking about comes out of the clinical practice guideline, the preservation of upper limb function. And it says following a spinal cord injury. It's written for spinal cord, but it really applies to anyone using a manual wheelchair. And so the facets of it have really been fun to implement. And rolling resistance has been also an interesting topic that I've kind of had a little bit of a kind of frustration with when it comes to the tire pressure and air tires. And early in my career, I was educated on how terrible the solid tires are. And this is a really good handout. It's from University of Pittsburgh. And it's like Wendy said, when you show it to consumers and you show them really the impact of some of their decisions. I know the vendors understand that air tires have a maintenance aspect that a lot of people aren't willing to do, but if the clinician can influence and help that person understand, it's worth it to get the air tires because you're gaining this much more positive impact with your equipment. We know it's going to take you time for the maintenance and making sure you have the right air pressure, but it's worth it in the end. And so I really encourage you to look this handout up. Look up this handout. If you can't find it, our contact is in the presentation that will get it to you. But also, really helping the person understand not only the durability, but if they have incontinence and looking at the different management with the skin and the cushion covers, transportation for new wheelchair users. And this is kind of outside of your traditional spinal cord injury, but somebody coming into the clinic that is looking at any type of power, people really do not understand the transportation options. And in Ohio, we don't have good community transportation, so it's individual. So really at least planting seeds and helping them understand what their choices are with that. And I already kind of talked about the tire inflation, but I'll let you kind of look through this handout. And if you cannot find the copy of it, we'll be happy to get it to you. Next slide.
And so let's dive into surgery. So the front half of our presentation was, what are ways that we can educate our clients? What are ideal setups and strategies, intervention we can do to prevent? But sometimes it's just, it's too far gone, and the functional loss, the degree of pain is too great. And so with surgery statistics, there's not a lot of research out there that I could find, but for our clients, education is key because this is scary to go this route. But 6 out of 7 found with these research of these 11 studies found significant improvement in pain, range, and functional outcomes. And that re-tear rate, it's definitely there, but not 90%, not 75%. And so for the arthroplasty too, I saw function and pain improvements with an even lower failure rate. So that fear factor can be big ones. Understanding what can happen. Talk with that physician, talk with your surgeon, the nurse, man, she or he can give you so much information, but typically completely braced and only passive range for 6 weeks. And that 8 weeks is not always the case. It can be up to 12, depending on the type of surgery that they did. And so 2 months at least until you're able to start transferring yourself and doing a slide board, likely transfer. That's a lot to consider. With equipment you have right now, what can we anticipate moving ahead? So consider how you can be positioned in bed to manage your pain, sleep, and support the surgery and not break your precautions. What kind of mobility tools will you need to keep your skin healthy? How are you going to transfer? Bathroom, with your neurogenic bowel or bladder, what are considerations from there? How are you going to access the toilet if you use that? Showering, those are things too. Do you have specific tools that might help with dressing? And I already said about the bathing considerations. And so transfers are a big one, and I'll go into the case study with that. That was kind of the biggest concern of my clients. She had a lot of trouble with her neurogenic bowel and bladder post-operative, and just having staff at the nursing facility not understanding what her needs specifically were. Skin protection is huge. If you cannot pressure relief and reach and be active like you had, what are methods in place for bed and chair to keep you as healthy as possible? And I helped develop with my client a whole list of questions when she was kind of interviewing the different long-term care facilities to help her kind of evaluate the differences between and see what would be the best match for her. And feedback I got was that was just super helpful to kind of take all those considerations into key. What is going to be your social network, your support when you do transition to home? Because likely that you're not going to be 100% like you were prior to surgery. And so what are those resources of friends, hired help, transportation that you can take from there. It's really common before a knee surgery to do strength and range of motion, isometrics, get that stable, get that strength and tone high. Same thing with the shoulder. We can give some programs from there. And then knowing that we can be that resource after surgery to help, well, what is that transition back to greater independence? Let me be your person. So I really love the New Mobility magazine, read it from cover to cover every month. And now I guess it's going to be every 2 months. But these are just some articles within the last few years specifically about shoulders. Some of these are about aging, others are about preventing surgery, others are post-surgery. And so just kind of pointing our clients in the direction to get someone different than the medical organization to give them impact. And so hearing it from a consumer perspective can be very, very helpful. Or consider someone that you've worked with that have had a shoulder surgery and let them be a peer mentor, maybe for somebody that's coming up to that.
Hey, Wendy, we have a quick question. Are the studies for neurologic conditions having shoulder surgery or able-bodied?
They were neurologic.
Okay, thank you.
Users, I'm sorry.
Thanks. Go ahead. We have about 10 minutes, so we can keep going.
Okay. So this client, I've known her for all of my 15 years that I've been working at the seating clinic with Theresa. She has neurofibromatosis, and because of all of those fibromas, she has had many, many surgeries, resulting in a hemipelvectomy, distal arm tendon transfer. She has very limited hand function, trunk and head control, and pain is a huge factor for her. She has both a customized manual wheelchair with custom seating, as well as group 3 power, all tricked out with custom seating for use in the home. She does drive, has an adapted vehicle that she enters with her manual wheelchair. She had a non-traumatic repetitive strain injury to her shoulder, and it got to the point she couldn't transfer. She couldn't reach. Her confidence with just seated balance was really poor, and she was having a lot of trouble with driving. Could not propel to and from, doctor's appointments from her vehicle, and that was kind of the breaking point for her. So when we were prepping for surgery, she came into me to talk about her wheelchair needs just in general. And we started talking about and listing down, writing, giving resources. These are things to consider. With her hemipelvectomy, she can't use a traditional partner sling. So I'm talking about kind of that upside down U. We don't have the thigh to reach upon. And so I wanted her to know that that was a big no-no. Do not let anyone ever try that with her. The rectangular sling is a much better option, but because you're going to be sitting on it at all times, you need to be mindful of if there's any wrinkles and skin health, how are you going to do your toileting, those things. And we practiced it in the clinic, and she was able to verbalize how she would suggest someone to put the placement of the sling close to the knee if there was a wrinkle. And so I kind of coached her of things of how she could advocate for herself. We talked about once she was cleared to put maybe a little bit more weight or have assistance with a stand pivot transfer of how she could protect the arm, the surgical arm, and what are considerations for stability to her left leg. She has avascular necrosis in that hip as well. So gave some seat height and kind of set up an angle of the chair. Those are all things that we trialed ahead of time. We trialed a slide board transfer, which she'd never done before. And she has enough trunk control to help with that. But that gave her some confidence to know that that was an option. We trialed the BZ board. She was not a fan, but at least we gave a whole list of options that were out there. With her power wheelchair, went through what options she had to keep her pressure relief up. Skin breakdown had not been a huge factor for her prior to the shoulder surgery. So that was really education to her of how often, how long, and we needed to find a way to support that surgical arm when she was in full tilt and recline. So we made some additions to her chair. We also figured out with her vendor of when she was ready for surgery of how to transfer that drive control to her opposite side. The surgical arm was her dominant arm. That's all kind of preparation ahead of time.
Less than 5 minutes, Wendy.
Mentioned earlier of the interview of the skilled nursing facility, some of those things to be taken into consideration. I sent her to our adaptive driving program to look at the way that she her vehicle was set up, and I gave her some home exercise program both for core, shoulder, and deep neck flexor strength training. After the surgery, she had lost a significant amount of weight, and we were creative with how we adapted her custom seating. When she was cleared to use that arm, we put the drive control back, and I just continued to be a resource for her. I was not her primary PT post-op, but when she was in skilled nursing as well as outpatient, I was just a resource for her. We are doing 6-month interval checkups just because of her medical complexity. She had a total with complications, and now she is prepping for a total shoulder on her opposing side. So a lot of follow-up with this client, and the collaboration with the vendor as well as the client confidence in us. It's wonderful to work with her. Very challenging, but wonderful to work with her over time. And I think it was just that early on of giving her the resources, giving her the confidence that, yes, I can do this. These are the things I need to consider and be ready post-op. So coming back to what our roles as a seating therapist are, be that person for our client. And I added a 4th one, that continued monitoring, education, and advocacy. Barry kind of tugged at the heartstrings this morning, and I love that quote that he had from Michelle Lang of, "The chair has not been living up to the potential of the person in it." So my question for you as a therapist is, are our interventions, our education, our advocacy, is that living up to the potential of the client? And so what are those resources and training tools that you can have? In the handout, I have the shoulder screen, some patient education materials for habits and management, monitoring of your pain, and some home exercise, as well as this presentation here. So don't hesitate to reach out to us and let us know if you have any questions right now.
Thanks, Wendy. We do have a couple of questions. I just wanted to let everyone know before we go to the questions, that client that Wendy was speaking of, extremely educated and a very good self-advocate. And she really needed Wendy to help guide and organize her. And even with that, I think she did struggle a little bit because she did get a lot of pushback, because sometimes we're not used to that person that's trying to really self-promote. And if you think of them, like she was interviewing subacute facilities before she went in. So she really was planning. And I think she taught us a lot about how much impact we can have. Would you agree, Wendy?
Yes, definitely.
So I think that those slides that Wendy has are, not all of us get that opportunity, but no, you all have that potential to make that impact. So I want to read a couple of questions. So Jody says, so difficult as well to find an orthopedic surgeon who is willing to accept input and collaboration from the spinal cord clinical team on how our clients are using their shoulders compared to abs, and how these wheelchair users expect to return to active and quality of life. Yes, Jody, I agree with you as well. Wendy, did you want to comment on anything in regard to that?
Yeah, it's just
able-bodied, not abs. Sorry, my old eyes.
Yeah, it's very different. And so I challenge my clients to talk with, who understands your neurologic components too. And so physical medicine and rehab for most of my clients have been a good kind of gatekeeper and good feedback. And so I suggest talking with a therapist who understands your neurologic diagnosis, as well as physicians that understand before you go into surgery. Because orthopedic therapists, orthopedic surgeons, they don't always have the full picture.
Thanks, Wendy. And Catherine, hi, Catherine. She says, thanks for the great presentation. And I've lost her. So do you find many clients still view manual wheelchair propulsion itself to be adequate exercise? How do you couch the concept that mobility is not the same as balanced exercise program, and when to add other tools for other activities to the toolbox? Power assist to avoid injury or further injury.
So with our history, with my measurements, pain, limitation in wheelchair skills, greater challenge with transfers, limited reach, there's your warning signs. Your body's changing. Your needs have changed. And so I can't do it for a client. You know, I can't make someone exercise, just like when I worked in orthopedics. But it's my role to kind of say, these are things that I'm noticing, especially if I've known you for a few years. Wow, I look at this data or look at these pictures from a few years ago, and just kind of comparative in that way. And it's depending on the person if they want the research and they want the numbers in that way. So it's just finding that way to connect with a person. And I challenge a person to try exercise for 3 weeks and see how you feel. What impact does this have? Or try a different style of transfer with this in mind. You know, it's just giving them one nugget to focus on. And does that have any positive impact? And so if you can make that kind of connection and they can see a positive improvement, you might get it going from there. And so definitely the power assist is not something we put in here, but that gentleman that I did have as a case study, he was getting a power assist to help him with community and work tasks. But it's just finding something that's relevant to that client.
Thanks, Wendy. So the handouts are in the portal. So there was a question about where the handouts are. So let me see. Oh, Mark is asking, I've been looking for the wheelchair propulsion norm values and cannot find anything concrete. Is that like meters per second, the propulsion? Is that what you're looking for, Mark? Do you have the resource for normative propulsion values?
Yeah, so that's from Smart Wheel data. That's kind of middle of the presentation. I make an Excel grid and I put what maybe the wheelchair configuration is, and then their wheelchair skill level and their propulsion analysis. And I show from current to trial to fitting, and I compare that on the far right to what's community norm versus minimal detectable change. And
so I think Mark might be looking for that. I know I have it somewhere, the article on
so 1.29 meters per second, which I'm typically doing a 10 meter, that's community norm, and 0.59 meters per second is the minimal detectable change.
Okay. So Mark, shoot us an email if you still need that. So the documents are accessed via the attendee hub in the tab for this session. And we're at 157. Great, Mark, thank you. The code, just so I don't lose anyone, is L as in llama, 7, C as in cat, V as in Victor, D as in dog, S. So it's L7CVDS. And it looks like, so very helpful presentation. We see quite a few people in our clinic with chronic shoulder pain and some contemplating surgeries for their condition. Thanks, Sue. Get them into your clinic. I think you have a lot of tools and resources that can help them. And Catherine also says, loves the value of photos over time, speaks volume, great idea. And lots of thank you, great presentation, wonderful presentation. So wish I could see you guys out there, but Wendy, any closing remarks?
No, I just beef up your orthopedic skills, and the consumer buy-in is huge. Not everyone wants to make dramatic changes, and that's okay. So starting small is a big deal. I don't rethink someone's chair that they don't have problems with. I still think that it's beneficial to give education of the risks at play for our clients, and the more resources we can provide them, the better.
Awesome. Well, have a great conference, everybody, and thanks for logging in.
All right, thanks.